Good morning, and welcome to day 2 of the June 2017 ACIP meeting. We're going to start with agency updates, and because Dr. Massoni has been held up a little, I'd like to start with some of the other agencies, and maybe I'll start, if it's all right, with Dr. Thompson. Are you available for NVAC?
She's not the agency update. She doesn't give one.
Although we've incorporated that into the NVPO, so, Dr. Chen will give that.
Thank you. Ms. Groom.
Hi, good morning. Just 2 quick things to report for the Indian Health Service. One is we had full implementation of our mandatory healthcare personnel influenza vaccination policy this flu season, and our final data shows that the agency did achieve the Healthy People 2020 goal of 90% coverage for our healthcare personnel across our agency. We're very happy. And then the second is just for fiscal year 2018, the Indian Health Service is implementing a composite measure to monitor adult compliance with adult immunizations for Tdap, TD-containing vaccine in the last 10 years, zoster, and pneumococcal vaccine. So we'll be implementing that agency-wide as a performance measure for fiscal year 2018. Thank you.
Thank you. Ms. Hans, CMS.
Thank you. I don't have any updates today, but thank you very much.
Thank you. We'll move on to DOD.
Good morning. This is Margaret Iacovoni for DOD Updates. First of all, the yellow fever vaccine shortage. The Defense Health Agency's Immunization Healthcare Branch continues to work with all branches of the service on mitigating strategies to conserve available doses of yellow fever vaccine. DOD has reduced utilization by more than 60%, maximized our stock with an aggressive redistribution program of short-dated vaccine, and partnered with Sanofi Pasteur on strategies to help delay on national stockout. Second, the Department of Defense adenovirus vaccination program. The DOD routinely vaccinates recruits to protect against adenovirus types 4 and 7. Early and initial entry training. Recently completed FDA-mandated post-licensure surveillance studies reported sustained reductions in acute respiratory disease and an excellent safety profile in this population following the reinstatement of a universal vaccination of recruits. These publications include one in infectious disease and another one in vaccine on the incidence of respiratory illness and also on the safety. Future goals of the adenovirus vaccine program include modernization of the adenovirus vaccine production, which we partnered with industry partners, and consideration for expansion of vaccination to military service academies in addition to our recruit population. For our Japanese encephalitis vaccine program, DOD has completed all JEV Exario FDA required post-licensure studies. A final manuscript of surveillance of adverse events was forwarded to the FDA this week for review and comments. In our metabolomics research, DOD completed a pilot study to assess metabolites as markers of adverse events following smallpox vaccination. This study demonstrated the potential for metabolites to identify mechanisms associated with subjects who develop adverse events following immunizations. That was published in Vaccine in March 2017, and that includes my update.
Thank you very much. FDA, Dr. Sun.
Hello, good morning. So first item is we had an advisory committee on May 17th, and this was the topic of discussion was how to move forward with the development of vaccines for infant immunization with RSV, given the past history of the formalin inactivated causing enhanced disease. So we have taken that advisory committee's feedback, and we're working with the several manufacturers on developing RSV vaccines for that population. And second, I wanted to give a brief update on the 21st Century Cure Act 2016 as it impacts vaccines. There are numerous provisions, but the one that I think most relevant to ACIP is the Title III, Subtitle C, Modern Trial Design Evidence Development, Section 3022, on the topic of real-world evidence. The Act requires FDA to establish a program to evaluate potential use of real-world evidence for twofold purposes. One is to support approval of new indications for an approved drug, and second, to fulfill post-approval commitment. And real-world evidence is defined as data regarding the usage or potential benefit or risk of a drug derived from sources other than randomized controlled trials. So these could potentially include safety, surveillance, observational studies, registries, claims, data, and patient-centered outcomes. And and I think the implication for this is that the impact of ACIP recommendation is going to be enhanced because we believe that the nature of ACIP recommendation that they will dictate how these real-world evidence will be able to be developed. And FDA is also charged with developing a guidance on this particular topic. So there may be, I think additional collaborations with the ACIP on doing this. Thirdly, we approved there was one supplement approved since the last ACIP meeting. This was on March 13th. The approval of Trumemba, which was originally approved in 2014, but this was the approval of the supplement of 3-dose series and the confirmatory study for the accelerated approval. Pfizer presented data from their breadth of coverage with using additional strains of meninge B and as measured with the serum bactericidal antibody levels. We also, part of that supplement also included data on the concomitant administration of Menactra, and that was also approved. And then lastly, just want to mention that Walt Orenstein, Larry Pickering, Carol Baker, and myself have submitted an article to Vaccines on the topic of ACIP and FDA collaborations with vaccines in the U.S. And we review the approvals from the last 10 years and ACIP recommendations. So look for that in the next few months. Thank you.
I think we'll all look forward to reading that. Thank you. HRSA, Dr. Nair.
Good morning. I just had a brief update. We've been very busy in the National Vaccine Injury Compensation Program. Thus far this year, we've received 853 claims. And as of March, $127 million in awards have been paid to petitioners, and $13 million have been paid in attorney's fees and cost. And that includes costs for compensation and dismissed claims, as well as interim fees. And as always, our website has up-to-date information about the program. The final rule, which made revisions to the vaccine injury table, was published earlier this year in January, and that's effective for claims that are filed after March 21st, 2017. And we're continuing to do outreach efforts to make people aware of our program, and that concludes my update.
Thank you. NIH, Dr. Lambert.
Yes, good morning. Thank you. It's a pleasure to be here and to update the committee. So we have 3 updates. The first is the initiation of a phase 1 clinical trial of a new recombinant RSV vaccine. And this effort was under the development of the Vaccine Research Center at the National Institute of Allergy and Infectious Diseases. The second update is the initiation of a phase 2 clinical trial of a Zika vaccine. And that is a DNA-based vaccine that showed promise in phase 1 clinical trials. And that is a 2-staged study design. It'll first enroll healthy adults, and then for safety and immunogenicity, and then the selection of a dose will trigger us to start the second part of that study, which is an expanded phase 2 up to 2,400 healthy adults, 15 to 35 years of age. And that study is scheduled to be undertaken in the continental United States, as well as in a number of countries that either have already had natural infection with Zika or are anticipated. So there's 6 additional countries. And the third and final update to this committee is to let you know that we supported late last year a workshop on waning immunity associated with microbial vaccines. And so that was recently published last month in an ASM journal, and it really looked at the knowledge, compared and contrasted 6 different microbial vaccines and what we know about them and their duration of protection, and set some recommendations for opportunities for additional research support down the line. So thank you so much.
Thank you. And NVPO, Dr. Shen.
Thank you so much. To update the committee, many of you know about the recent departure of our NVPO director, Dr. Gellin. Since the last ACIP, he's left federal service and is now serving as a leader at the Sabin Vaccine Institute. A second update speaks to the National Adult and Influenza Immunization Summit. On May 9th, NVPO with CDC and the Immunization Action Coalition co-chaired the IAC-hosted 6th Annual National Adult and Influenza Immunization Summit. We had participation from over 350 attendees. These attendees represented 150 different organizations across the federal space, local and state health departments, professional associations, foundations, networks, academia, and the such. The theme that we had this year was called Prioritizing Prevention, Strategies to Improve Adult Vaccination Within Transforming Health Systems. This year, we also had a pre-meeting on leveraging and transforming health systems to improve adult vaccination, which was co-sponsored by AMGA and the summit. My computer blanked out a bit. So then, one moment. I knew I should have printed this. So we will be producing a white paper from that pre-meeting. It's forthcoming. And the slides, if you're interested, are on the summit website. Also related to adults, NVPO co-leads with Indian Health Service, the Summit Working Group on Quality and Performance Measures. A few updates on that. We have a contract through NCQA, and we're currently right now had finished recruitment, and through the summer, we're testing our maternal immunization composite measure. As you know, that includes Tdap and influenza. Which will land into the HEDIS data set. So many of you who work in these health systems appreciate the implications of being part of HEDIS. Through the summit, we will also be landing our ESRD measure working group as we've engaged with CMS's ESRD program, including their quality incentives program, as well as the networks program for quality improvement in programs. And so their need to look at measures for the ESRD population, influenza, pneumococcal, and hepatitis B. Our last working group around the adult composite, we'll have an update for this committee in the fall on the progress of that. The composite is comprised of Tdap, pneumococcal, zoster, and potentially influenza. With regard to the Cures Act, there's a specific provision that you may be interested in. NVPO is leading the HHS Interagency Working Group, which is comprised of FDA, CDC, NIH, and BARDA, on delivering on Section 3093. This requirement requires the Secretary of HHS to deliver a report to Congress around vaccine innovation. This report is due in December, 1 year from the enactment of the law. Earlier this month, NVPO announced the winners of its inaugural Upshot Awards, celebrating the great work being done to enhance the vaccine immunization system. Excellence in safety went to Roger Baxter. Excellent in vaccine communication went to William Schaffner. Excellence in vaccine supply, access, and use went to HLN Consulting. And excellent in global prevention went to PATH. With regard to NVAC, which was held earlier this month on June 6th, we framed our meeting around the top 3 opportunity areas as identified by the NVAC mid-course review. So the 3 sessions focused on IAS, vaccine confidence, and financial and systems barriers to administration of vaccine, those provider barriers, separate from the consumer barriers for which a lot of the Affordable Care Act addressed. Slides will be available on the website, on the NVPO website, in about 1 week. And lastly, the PAC-CARB, the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. PAC-CARB, as you have heard from Dr. Gellin in previous meetings, is charged with developing recommendations on incentivizing development for therapeutics, diagnostics, and vaccines. The vaccines working group you may be interested in, their draft report was presented at the May public meeting, and which did not include their recommendations. So their full report will be presented this fall at the September 13-14 PAC-CARB meeting for a full vote of the Advisory Council. To remind you, the recommendations of that council go to the Secretary, who then transmits that to the President. And a number of our NVAC members also sit on that working group. Thank you for your time.
Thank you, and congratulations to Dr. Schaffner. CDC, Dr. Massonia.
Good morning, everybody. I would just say that there are a number of really important and great things going on in NCIRD. We have this new lovely 2-pager, which was at your seats, but knowing that Dr. Bennett wants to keep us expressly on time, I'm actually going to cede my 3 minutes to Amanda.
Thank you. That's probably the first and last time that will ever happen. Just kidding. So we wanted to take this morning as an opportunity to acknowledge someone who has really been the heart and the soul of ACIP for so many years, Captain Jean Smith. Jean, will you, where are you? Okay. Come on. Great. So she's rarely put on the spot, but Jean is moving into a new position at CDC, so we wanted to take a minute to acknowledge her. Next slide. So Jean joined CDC 25 years ago as an EIS officer, where, thanks to Google, I found this article about her where she was featured regarding a foodborne outbreak that she worked on among bankers, which she ended up tracing back to eggs of a caterer who was making homemade mayonnaise. So she started saving the world many, many years ago. After EIS, next slide, Jean's dedication to public health took her to live in India and Nepal, where she worked tirelessly for years on polio eradication during a time where enormous progress towards elimination was made in the region. Next slide. In 2006, Jean became the medical officer for the ACIP Secretariat. This is what the childhood immunization schedule looked like in that year. Fast forward to the next slide. 11 years later to the current immunization schedule. But what I really wanted to say is there's so much behind each of these recommendations, and Jean has really spearheaded the many critical improvements in terms of the way ACIP functions, including grade, evidence-based recommendations, the guidance for economic analyses, and the way they're presented to ACIP. But more than anything, Jean has been an advisor, a mentor, and a support for dozens of CDC staff, and I tried to count last night over 40 ACIP members over the years. Next slide. So while Jean will always be part of the ACIP family, next slide, we are so grateful for her tireless efforts to bring ACIP to where it is today, all while raising her beautiful daughter, pictured here. I should tell you that it was very, very challenging to find pictures of Jean because she's always in the background. She doesn't like to have her picture taken. So we're excited for you in your new role. You will not be far away from us. She'll continue to work in educating providers about ACI recommendations, and we just wanted to thank you publicly. Thank you.
I just want to say, first of all, thank you. Secondly, I turned 65 in March. I'm the 65-year-old mother of a 19-year-old daughter. There is no retirement for me in the cards anytime soon. And yes, I have started receiving piles of Medicare mailings. Thank you very much.
One more, and then we'll get started, sorry.
Wait, the two short people should be on either side.
I'm a giant, right?
Thanks.
Thank you. Thank you so much, Jean. There's no way we can ever express how much you've meant to all of us. I can tell you personally that I never would have taken this job were it not for Jean, so. Okay, I guess we're going to get started. We're starting with dengue this morning, and Dr. Walter.
Did you say Dr. Walt? Oh, it is Dr. Walter. Dr. Walter?
Good morning. So I'm here to kick off the Flavivirus session, first with an update on dengue virus vaccine and where we are. This is a listing of the members of the dengue virus working group. For the ACIP members, it's myself, Dr. Atmar, and Cindy Pellegrini. And you can see here we have a whole list of folks from the CDC, ACIP liaisons, ex officio members, and technical advisors. So at the February meeting, just to remind you, we had an update on the general dengue epidemiology at that meeting and also on vaccine development. And since that time, the work group has met about every 2 weeks and continued review of dengue epidemiology, immunology, and diagnostics to prepare for submission of the dengue vaccine BLA. This was all done, as I mentioned, in anticipation of a submission of a dengue vaccine BLA, which is now, we are told, been delayed. We had anticipated initially that it would be submitted this year, and we're told that it probably will be sometime next year. So our future work group plans have been slowed up, I think, a little bit. We hope to continue to review dengue vaccine clinical trials, review the cost effectiveness of dengue vaccines. We hope to have presentations in the future by Sanofi Pasteur. We hope to review grade and draft recommendations for use. So today, in preparation for all this, we're going to have a presentation. We have Dr. Waterman from the CDC, the dengue branch in Puerto Rico, and he's going to give us an update on dengue epidemiology in the U.S., Puerto Rico, and other U.S. territories.
Okay, good morning. All right. Thank you. So I did speak on dengue epidemiology last February, but I'm going to give a little bit of a recapitulation and then go through the geographic areas of the U.S. And its territories that have been affected by dengue, and they're sort of listed here in descending order of intensity of transmission, and I'll end with a brief summary. There are 4 dengue serotypes. Infection with a single serotype leads to long-term protection, and short-term, maybe up to 6 months, cross-protective immunity to the other serotypes, but theoretically you can be infected 4 times with the 4 different dengue serotypes. Dengue is transmitted by the bite of an infected Aedes mosquito in a mosquito-man cycle without any intermediate hosts. Dengue is arguably the most important arbovirus worldwide in terms of morbidity and mortality. As you can see, estimates are that there are 100 million dengue infections in a year worldwide, dengue clinical cases, many more inapparent infections, and 20,000 deaths a year, and these occur in the Western Hemisphere, Africa, Asia, where the most intense transmission occurs, and in the Pacific. Dengue is an acute febrile illness syndrome resembling other infectious diseases such as measles, leptospirosis, rickettsial diseases, often has a rash. It's interesting in that it's endemic. It can be transmitted endemically, but also tends to occur in cycles over several years, and we'll see some curves of that. It's highly seasonal, usually associated with high rainfall periods in a given area. In the highly endemic areas, there are often multiple dengue serotypes circulating. And the peak age of incidence varies by region depending on the intensity of transmission. The peak age tends to be younger in those areas where where transmission is highest. Severe dengue is a natural progression of the disease. A distinct capillary leakage syndrome can occur several days into the illness and is potentially fatal, although with adequate fluid support, the mortality should be reduced to less than 1%. The risk factor that has been most emphasized with dengue is secondary infection with a second serotype, and the pathophysiology is probably related to immune-mediated phenomenon. Viral strain and host factors such as age and comorbidity are also risk factors for severe illness. So today, in terms of talking about a risk framework and considerations of vaccine, obviously we want to focus on areas where dengue is locally transmitted and the vector is present. And for the U.S. territories, we're talking about the Caribbean, Puerto Rico, the Virgin Islands, and the Pacific Islands. The vector is present in many parts of the southern United States, but with really non-endemic situations. The outbreaks have occurred in the Texas, U.S.-Mexico border, Florida, and Hawaii, and areas such as Louisiana and Arizona have had are at risk because of importations, the presence of the vector in abundance, and proximity to endemic areas such as Mexico in the case of Arizona. Obviously, we can have imported cases of dengue in areas where the vector is not present. So really going to emphasize Puerto Rico here today. Puerto Rico has a history of major epidemics, first reported in 1915 to 1945. Dengue virus was first isolated in Puerto Rico in 1963, and dengue hemorrhagic fever, the severe form of illness, was first identified in 1975. The first time more than one dengue virus type was found to be circulating at the same time was during the 1977 outbreak, in which 3 viruses were detected, and between 1969 and 1886, there have been 6 large island-wide outbreaks. The main vector in Puerto Rico is Aedes aegypti. There's another Aedes species, but has not been involved in transmission that we've documented to date. The outbreaks can have as many as 27,000 reported cases through the passive surveillance system. And multiple dengue viruses have been co-circulating in Puerto Rico since the 1980s. There's a seasonal incidence with the rainy season and the summer, fall months, higher incidence in the urban areas, and the highest incidence of clinical disease is in 10 to 19-year-olds with no difference by sex. Again, the outbreak cycle, you can see the 2 large outbreaks in the late 1990s and the 3 large outbreaks in the 2000s here. The virus serotypes that predominate vary over time. And early on, you can see that dengue 2 and 4 were important in the late 1980s. And this is cycle dengue 3 came in the late 1990s and now is at relatively low levels. Most recently, we have had all 4 serotypes circulating. Dengue 4 is the most common, and dengue 2 seems to be making a comeback. In terms of the age distribution of cases in Puerto Rico, 49% of all lab-positive cases are adults, and the median age is 18 years during the surveillance from 2010 to 2012, and obviously the age range goes from birth to centenarians. Again, looking at the 2010 to 12 data, the fatal cases track the laboratory positive case surveillance data, fatal cases in the red bars. We had 39 deaths during 2010 for a rate of 1 death per 100,000. In 2011, 6 deaths, and in 2012, 13 deaths. While the age incidence of clinical disease is highest in 10 to 19-year-olds, the deaths in Puerto Rico tend to be focused in the older age groups, as you can see in this slide. 90% in the older age groups with a median age of 46 years among the deaths. The seroprevalence of dengue infection and the proportion of primary and secondary infections is an important consideration in thinking about the dengue vaccine. A serosurvey among blood donors only conducted among adults in 2006 showed that 92% of these adults were seropositive, and most of the infections were secondary infections. Another evidence of the high seroprevalence of dengue in Puerto Rico is looking at the lab-positive cases. 80% of all our infections were secondary, and primary infection was only common in 1 to 4-year-olds. Moving to the U.S. Virgin Islands, about 60 miles to the west of Puerto Rico, and based on their passive case reporting, U.S. Virgin Islands has experienced periodic outbreaks. You can see between 1986 and 2012. During the 2012 outbreak, a school serosurvey was conducted and showed that 20% of these students were recently infected during the outbreak. And again, when we looked at the school teachers compared to the children, a very high percentage of the school teachers, around 80%, had evidence of prior infection. Moving to the Pacific Islands, dengue has been reported with outbreaks since 1958. In the Pacific Islands, we're talking about multiple Aedes species, Aedes albopictus, Aedes aegypti being the most important, but other species as well. While transmission is continuous and outbreaks are commonly reported, they're usually only one serotype circulating at a given time. We conducted a serosurvey in 2010 in American Samoa, again among adults only, and 96% of the population was seropositive. During a dengue outbreak in 2015 that CDC collaborated on, there were 479 suspect cases, which is 1% of the population. The incidence was highest in individuals less than 25 years of age. It was a dengue 3 outbreak. There were 4 fatal cases for a case fatality rate of 1%, and the most common vectors were Aedes polynesiensis and Aedes aegypti. Moving to the U.S. States, the continental United States, the area that has been most at risk has been the U.S.-Mexico border, particularly southeast border region with Texas and Mexico, the so-called lower Rio Grande Valley. We'll talk about a number of outbreaks there, but there have also recently been outbreaks in and along the Mexican border in Arizona and California, and Aedes aegypti has recently been identified in California, so the potential for future outbreaks in the Southwest is quite evident. Texas has an impressive history, actually, of dengue. Their first outbreak was reported in 1885 in Austin, where purportedly over 70% of the residents were affected. And there was a large outbreak in 1922 with over 500,000 cases throughout the state. But since World War II, really, outbreaks have only occurred since 1980, and these have been small outbreaks, again, in the lower Rio Grande Valley, in which a good number of cases were identified that did not have a travel history across the border to Mexico. But again, these outbreaks are occurring in the context of large outbreaks on the Mexican side, and then a smaller number of cases occurring on the U.S. side. One such outbreak was investigated thoroughly in Laredo, Texas, which borders Nuevo Laredo, Tamaulipas state in Mexico. You can see the satellite image with the Rio Grande River going in between these basically contiguous communities. Despite a higher Aedes aegypti presence on the U.S. side in this study, the incidence of IgM recent infections on the Mexican side was an order of magnitude higher, but at the same time, On the U.S. side, there was a IgG prevalence of past infection of 20 to 22% at that time. Again, evidence of local transmission on the U.S. side, and this outbreak has often been cited, publication by Paul Ryder, as the epi data suggested that air conditioning and housing conditions on the U.S. side were what was making this big difference in incidence between the two sides of the border. Another binational outbreak investigation took place in Cameron County, which is where Brownsville is, and its sister city of Matamoros in Tamaulipas. In 2005, again, a serosurvey suggested much higher incidence on the Mexican side. This time, the U.S. seroprevalence of IgG was 38%, and of the persons in the serosurvey who did not have a history of travel across the border, 25% were seropositive for IgG, suggesting considerable local transmission. This outbreak was transmitted involved a Dengue 2 Southeast Asia strain, which has been associated with severe disease. This was the first time dengue hemorrhagic fever was identified in the U.S. Of the reported cases, 89% were hospitalized on the U.S. side, and 16% of them had dengue hemorrhagic fever. Again, a very large outbreak on the Mexican side with many, many hospitalizations. The last outbreak that's been investigated and detected in Texas was a Dengue 1 and 3 outbreak in Cameron County in 2013. Over 50 laboratory positive cases with 55% hospitalized and 49% locally acquired, and a cluster survey among household members of positive cases detected additional infections, again, strongly evidence for local transmission in Texas. Let's move to Florida, which has had a number of outbreaks since 2009 in Rowe County, which is where Key West is, which is the string of islands off the end of Florida, experienced a Dengue 1 outbreak. Serosurvey indicated that 5% of the residents in the central Old Town area of Key West had a recent dengue infection. This outbreak continued on into the next year when 66 cases were identified. Between 2010 and 12, there have been 3 episodes of sporadic dengue documented with local transmission. 2010, in Miami-Dade and Broward County. In 2011, Miami-Dade, Palm Beach, Hillsborough, and Martin counties. And in 2012, Miami-Dade again, and Seminole and Osceola counties. Outbreak was documented in Martin, St. Lucie counties, in another part of Florida in 2013. And there was 1 sporadic case in Miami-Dade County that year. Again, not a very large outbreak. The median age was 48 years, but again, most of these cases were white persons, not Hispanic persons necessarily, who might have had a travel history to the Caribbean, and again, evidence of much local transmission. Seroincidence study suggested that 7% of the residents were infected, and when we looked at the sequencing of the virus in Martin County in 2013 compared to the 2009 virus in Key West, they were different viruses, so this was reintroduction and not ongoing endemic transmission in Florida. Hawaii is the last U.S. state that we'll talk about. It's also had a history of dengue outbreaks, but then quiescent after World War II for a period of time. Aedes aegypti was first introduced into Hawaii, and then Aedes albopictus came in a little bit later and has become the dominant mosquito in Hawaii. So 2001, an outbreak was detected that affected 3 of the islands, Kauai, Oahu, and Maui, with 2/3 of the cases in Maui, over 1,600 suspected cases, 122 laboratory positives. A very small village called Nahiku on Maui was where a serosurvey was conducted, which suggested a 39% attack rate. The median age during this outbreak was 41 years. 3 patients were hospitalized. There were no DHF cases, and this was an Aedes albopictus transmitted outbreak. And the genotype was a Tahitian strain, which is important, as we'll talk about another outbreak in a second. There's a very small cluster of cases in Oahu in 2011, where 5 laboratory positive cases were identified, the index case being a traveler from the Philippines, which is all very localized in a small neighborhood. These were not severe illness cases. Outbreak occurred recently in Hawaii in 2015 on the Big Island. There were 246 lab-confirmed cases. 14% of the cases in initial data were hospitalized. The median age was 29 years. This was a dengue 1, a different strain from the strain from the 2001 outbreak. Again, predominantly Aedes albopictus, although there were small communities that had Aedes aegypti that might have contributed to the transmission. So in summary, dengue is highly endemic in Puerto Rico with simultaneous circulation of multiple serotypes. While the seroprevalence data is limited, it strongly suggests that most of the population has had at least one dengue infection by the 2nd decade of life. During large outbreak, there are many hundreds of hospitalizations and tens of deaths occurring. Dengue is also common and may be endemic in the Virgin Islands and American Samoa and other U.S. territories. Again, we need more seroprevalence data, but again, suggesting there's a large proportion of the adult population has been infected. With regard to the U.S. states, South Texas has had repeated small dengue outbreaks with local transmission since the 1980s. And the interesting thing about the U.S.-Mexico border is that seroprevalence data, now over 10 years old, suggests that a subpopulation, a border-crossing subpopulation, has had significant past exposure to dengue. There are other U.S.-Mexico border states at risk for dengue, but no evidence of local transmission. Reported, Florida has had repeated small dengue outbreaks since 2009, and Hawaii has had the 2 outbreaks with a small cluster since 2001. Hawaii is different in that Aedes albopictus seems to be the primary vector. So that's the update on dengue epidemiology, and I'd like to thank my colleagues at the dengue branch, Dr. Margolis, and the health departments that we've collaborated with in gathering this data. So thank you.
Thank you very much for that very comprehensive summary of what's going on with dengue. Do people have questions or comments? I guess we're going to move on to yellow fever then. Dr. Walter. Thank you again.
So I'm going to introduce the next session for the Flavivirus Working Group. I guess since we switched viruses, I get to come up here and introduce the next series of speakers. So we're going to talk about yellow fever virus and yellow fever virus vaccine mostly. And again, I want to acknowledge the work group members. So I think we all know that there have been intermittent production issues that have resulted in temporary supply shortages of yellow fever vaccine, or YFVax, in the U.S. So starting in November 2015, ordering restrictions have been in place for yellow fever vaccine, or YFVax, due to supply shortages. The ACIP was briefed about the production and contingency plans to address supply shortages during the October meeting of last year and then this year's February meeting. So today we're going to have 2 presentations. The first will be a presentation and an update On the IND protocol under expanded use authorization, the protocol will be presented, the implementation and vaccine distribution by Dr. David Greenberg of Sanofi Pasteur. And then Aaron Staples from the CDC will come up and review the current ACIP recommendations and protocol criteria. I do have to make a comment here that Aaron, probably the very first time she thought of yellow fever vaccine was when she was a fellow working with me in travel clinic at Duke. So it really gives me great pleasure. She has obviously thought about it a lot more since leaving Duke.
Thank you. I'd like to thank Chip Walter, Steve Waterman, CDC staff for giving me the opportunity to update ACIP and audience about the update on the Expanded Access IND program. To improve supply, we are in the process of transitioning manufacturing of YFVax, our U.S. licensed yellow fever vaccine, to a new state-of-the-art facility that is expected to be operational by mid-2018. Manufacturing issues indeed resulted in an inability for us to bridge the gap between the shutdown of the old facility and the running of the new facility. So in response, as Dr. Walter just mentioned, we instituted ordering restrictions that have stretched the supply of our remaining doses of YFVax. But we are expected to stock out of YFVax by early July of this year. Our goal has been to maintain a continuous supply of yellow fever vaccine for travelers, government staff, military, and others who need to be immunized. And to accomplish this task, we've been in discussions with major stakeholders, including CDC, FDA, DOD, and others to manage the remaining supply of YFVax and to institute a program in which we would import an alternative yellow fever vaccine. An essential component of the stakeholder discussions have been with working closely with FDA to import Stamrel. This is the yellow fever vaccine we manufacture in France, but it's not licensed in the United States. We would be doing this under an IND and distributing it in the United States via an expanded access program, or EAP. The EAP program allows for Stamrel to be distributed to authorized healthcare providers who undergo training and certification through Sanofi Pasteur. And as a result of these efforts to maintain a supply of yellow fever vaccine in the U.S., we started shipping Stamrel to these EAP certified sites on May 23rd. As noted previously, we manufacture Stamrel in France using exactly the same live attenuated yellow fever vaccine 17D-204 that is contained in YFVax. Stamrel vaccine has been used in more than 70 countries for over 30 years, and some 430 million doses have been distributed globally. And the packaging is shown on this slide. The lyophilized yellow fever virus is supplied in the vial, and the diluent is supplied in a pre-filled syringe. CDC staff collaborated with us to publish this report on the yellow fever vaccine shortage in MMWR that appeared online on April 28th. And it reviews the events leading up to the shortage, our collective efforts to provide continuous supply of yellow fever vaccine in the U.S. despite the shortage, and the process of selecting and certifying the Stamrel sites. And that's noted on this slide. We are in the process of enrolling about 250 clinical sites to administer Stamrel vaccine to patients under this EAP. And we sought to have Stamrel vaccine available at the highest volume clinical sites in the U.S. because they would be most likely able to handle many patients coming in seeking vaccination in the limited number of sites. Therefore, sites where more than 250 doses had been ordered in 2016 were asked to participate in the EAP. And in addition, multi-site organizations that collectively ordered more than 250 sites were offered to have a single site for the EAP program. Now, lower volume sites were added, especially in states and territories that otherwise would have been without a site based on the high volume requirement. So we have all 50 states, Washington, D.C., and territories covered. Site personnel at these sites are required to follow the EAP protocol, undergo training, obtain informed consent from patients who will be vaccinated and from parents as appropriate, track use of the vaccine, and report adverse events to Sanofi Pasteur, to our global pharmacovigilance, and then to the FDA. Healthcare providers in clinical sites around the country not participating in the Stamrel EAP have been notified to direct their patients to Stamrel sites that are available by CDC at the URL shown on the slide. So now an update of the current status of site preparation. So as of yesterday, 2 days ago, 250 sites have been confirmed, have confirmed their interest in participation in the program. 207 of these sites have signed the protocol agreement. And of the remaining 43 sites, they are waiting for their own internal management approvals or their own local IRB approval. But they're working on those activities now. 199 sites have completed their training. 175 sites have their IRB approval. And 128 sites now have ordered Stamrel, some 13,000 doses so far. 17 originally invited sites have declined participation. They're mutually exclusive from the 250 that I show there at the top of the slide who actually have confirmed their participation. So in summary, Sanofi Pasteur expects to be out of stock of YFX in early July. Stamrel vaccine is now being distributed in the U.S. under this IND, an expanded access program that was reviewed and approved by the FDA. We're in the process of enrolling 250 sites to be up and running soon. And as of this week, 250 sites have confirmed their interest, 199 or almost 200 have been trained, and 128 have Stamrel in the refrigerator for their patients coming in. The CDC Yellow Fever website, again with the URL shown on the slide, is regularly updated with these sites. So healthcare providers and others can go to that site to find the Stamrel sites. And we will continue to supply these designated sites until the new YFX production becomes available in mid-2018. And I thank you for your attention.
Thank you very much. Why don't we go on to Dr. Staples, and then we'll take questions. Thank you.
Thank you, and good morning. The main objective of my talk is just to highlight the differences between the current ACIP recommendations and the Expanded Access Program, or EAP, IND protocol for Stamrel for ACIP's awareness. The current ACIP recommendations were published in 2010 and recommend the use of yellow fever vaccine in persons aged 9 months and older who are traveling to or living in areas at risk for yellow fever virus transmission. Because of rare but serious adverse events, healthcare providers should vaccinate only persons at risk for exposure to yellow fever virus or require proof of vaccination for country entry. To minimize the risk of serious adverse events, healthcare providers should observe the contraindications and consider precautions to vaccination before administering this live attenuated viral vaccine. As just was reviewed, during the period when YFVax is going to be unavailable in the United States, Stamero will be available only at selected clinics through an IRB-approved protocol. Persons needing yellow fever vaccine will be screened for inclusion and exclusion criteria. Consent and, when applicable, ASENs will be obtained prior to administering Stamero. Since Stamero has been available for decades outside the United States and has a safety profile similar to YFVax, adverse events possibly related to vaccination and serious adverse events will be passively collected rather than solicited. And then persons who receive the vaccine in the clinics that are administering the vaccines are, as just mentioned, recommended to inform any of these adverse events to Sanofi Pasteur rather than VAERS. Overall, the ACIP recommendations and the protocol criteria are very similar. This slide shows contraindications under the ACIP recommendations and exclusionary criteria for receiving Stamero under the EAP protocol. Allergy to vaccine components, age less than 6 months, symptomatic HIV or asymptomatic with severe immunosuppression, thymus disorder, primary immunodeficiencies, malignant neoplasms, transplantation, and immunosuppressive and immunomodulatory therapies are common between the two. There are also 3 precautions that are common between the current ACIP recommendations and the EAP protocol, namely pregnancy, age greater than or equal to 60 years, and asymptomatic HIV with moderate immunosuppression. With these groups particularly, they will be counseled about the risks of the disease versus the risks of vaccination, and then the decision to vaccinate will be based on that. There are 3 differences between the current ACIP recommendations and the EAP protocol criteria. The first is persons with asymptomatic HIV infection with no evidence of immune suppression. Under the current ACIP recommendations, these individuals should receive the vaccine if they're at risk for coming in contact with yellow fever virus or need it for proof of country entry. Under the current EAP protocol, however, they're listed as a precaution to vaccination, but this should not necessarily impact the ability of the persons with these conditions to receive the vaccine if they're truly at risk for acquiring the disease. Age 6 to 8 months is currently listed as a precaution under the ACIP recommendations, but in the EAP protocol, it is an exclusionary criteria, meaning infants aged 6 to 8 months will not be able to receive Stamero while we have YFVax unavailable in the United States. This is also true for breastfeeding, which is also listed as a precaution in the ACIP recommendations to vaccination, but is an exclusionary criteria unless breastfeeding can be discontinued for 14 days following vaccination. Since infants aged 6 to 8 months and breastfeeding women could previously receive yellow fever vaccine, but will be excluded to receive the vaccine under the EAP protocol. We currently are advising these groups to defer travel to risk areas if possible. If that is not possible, then to use strict mosquito prevention measures to lower their risk of disease. And with that, I'd like to end. Thanks.
Thank you very much. Questions for Dr. Staples or Dr. Greenberg? Dr. Schaffner.
Yes, thank you. For Dr. Staples, I was under the impression that 1 dose of yellow fever vaccine would be sufficient for lifetime protection. Would that not be, perhaps you might call it a deferral criterion? If you don't really need it, why get it?
That's correct. The current ACIP recommendations that was approved in 2015 do have the booster dose of yellow fever vaccine that was previously recommended every 10 years has been removed for most individuals. This protocol specifically will be addressing people who have not received the vaccine before and are seeking the vaccine to protect themselves against the disease.
Dr. Reingold?
Sorry, could you put up the last slide again for a second? I just have a quick question. I was a little unclear. So is this saying that these people would go, if the travel cannot be avoided, they would go unvaccinated and would rely on strict mosquito prevention measures?
We would again ask them to defer travel, but people have different plans and different things, and so they will not be eligible to receive the vaccine. So the next other prevention measure that is to use mosquito precaution. Again, it would be preferred that they defer their travel if they can, but not everybody can.
Well, and of course, many countries, they wouldn't be allowed to enter without a yellow card showing they'd had a yellow fever shot, so.
Dr. Hunter?
Yeah, I have a set of 3 questions, the first 2 of which you might want to answer with brief questions because the last one might be a little bit more involved, and they're all related. And it's regarding the selection of the Stamaril sites, so I don't know if which of you 2 would be more involved with this. So the first question is, what percentage of travelers get the recommended vaccine? And then the second question is, are those non-adherent travelers geographically concentrated? And if they are, wouldn't the site selection process that emphasizes previous high utilization clinics potentially increase non-adherence by decreasing access?
Well, to address the first question or related around the selection of the sites, indeed it made sense for us to seek out the highest volume centers, both because they've traditionally and historically ordered the greatest number of doses, and they were thought to be the most apt to be able to handle individuals who might not have otherwise gone to that clinic, but from the surrounding area to go to that clinic for vaccination. So the high volume sites are indeed spread across the country, and we've attempted to fill in gaps with lower volume sites, and so they are distributed across the U.S.
There have been some surveys conducted of travelers who present to travel clinics and are seeking potentially to have advice about receiving vaccines. So that's already a selected population. But when you look at that population of travelers, the group that tends to not be aware or potentially even want to accept the yellow fever vaccine tends to be people that are originally from or visiting friends and family in endemic areas. So we do know that that group in general, not just for yellow fever vaccine, but for some other prevention measures, are one of the groups that may not necessarily get the vaccine. Understanding the actual volume of travelers or proportion of travelers that choose not to get the vaccine or never get the vaccine is challenging. We've tried to conduct a pilot survey previously among airports, but really getting at the population that's going to be traveling to an at-risk area. When you're going to a place like Brazil, most of the places that people travel are outside. So we don't have good information about the overall acceptance among just anybody getting on a plane. So in terms of the geographic concentration, obviously that's a challenging question, but many of the people potentially at risk will be in high population centers, whether it be in New York City or another location where there are several Stamaril selected clinics. So we do hope, but we are working very closely with Sanofi as we phase into running out of YFX to understand if there's going to be critical gaps that need to be filled and work with them to address that.
Thank you. Dr. Freihofer?
Sandra Freihofer, American College of Physicians. This is a follow-up question to Dr. Schaffner's question. So ACIP recommends a once-in-a-lifetime vaccine, a dose of yellow fever vaccine. But some of the countries in which people may travel haven't quite caught up to that, even though the World Health Organization has approved that once-in-a-lifetime vaccination. Are there any steps being taken to get those countries, with the program and understanding that a one dose in a lifetime is good, so these patients that have had their yellow fever vaccine can travel? And the other part of this question, so for the longest time we've required an every 10-year booster. So some patients might have gotten a yellow fever vaccination years ago and may not have that documentation. Is there any thing that their physician can do to sort of renew that documentation and certification?
Yeah, so the larger question about whether countries adhere to what was recently approved and supported by the World Health Assembly in terms of no longer requiring proof of vaccination every 10 years, that is something that WHO is working with countries on. What we are doing at CDC is we try to keep as most updated information available on the Travelers Health website, so a traveler can go there and find out what the country is or is not requiring currently. But it is an ongoing discussion with certain countries about that regulation and the need to show proof of vaccination. We have historically had people who have lost their yellow cards, and there is specific information under the international health regulations that you can reissue it, but it really should be done, with validation that the person received it at the clinic, going to the original clinic and saying that they were vaccinated, and then another provider, or preferably the clinic that previously administered it, can re-administer the yellow fever card and stamp it with the information.
And if I could just add for clarity that the EAP protocol is agnostic to prior doses. If the healthcare provider at the Stamrel site believes it's appropriate to immunize that person, then they follow the AAP protocol if the person meets the inclusion-exclusion criteria, and there's no exclusion for someone who had previously received vaccine many years ago. They're to follow the ACIP recommendations, but ultimately it's the healthcare provider decision whether or not to administer it, and they'll administer it under the EAP protocol.
Dr. Moore?
Thank you. In my state, 2 of the clinics that are going to be taking Stamrel are public health departments, and we've discussed the fact that this is a public service, that because they are high-volume travel centers, it's important for them to make sure vaccine is available in their area, because otherwise folks would be traveling hours to reach a clinic if they didn't participate. And I was wondering, their hesitation had to do with the extra amount of time it would take to administer Stamrel to a patient compared to a routine yellow fever vaccination. Because they're high volume, that extra time then obviously is amplified because they'll be dealing with so many more patients. About how much extra time does it take in administering the Stamrel to go through that EAP process for a patient?
It really is just a matter of the informed consent. So, the very first patient, maybe an extra 20 minutes or something, but by the time you get to patient 10 or 100, I would imagine, the informed consent process is of course important, but I don't imagine it's going to take very long. It's really the same counseling that healthcare provider should have provided when they were administering YFVAC. So of course a little bit longer. I don't have the exact number of minutes for you, but I don't think it's going to be a burden.
Okay, great, thank you.
Dr. Thompson?
Yeah, I just wanted to comment that in most of the countries, according to the WHO UNICEF vaccine schedule currently, the countries that have yellow fever vaccine in their schedules generally deliver it routinely 1 dose at 9 months or after. So the kids that are under the 6 to 8 month olds that would be not having vaccine would not be eligible for the vaccine even in country. So there would be, an interesting discussion around whether those kids could be left out or excluded from country entry because they don't have proof of vaccine, which would not be relevant in the country they'd be entering, or not, the kids wouldn't be eligible. And then I think the bigger question on the breastfeeding women, I guess I wondered if there was what the evidence was behind the exclusion there. Was there a study that showed that there was risk of passing on the virus from the vaccine to the infant, or is that something that hasn't been studied, it's just precautionary?
No, thanks for pointing out the lower age limit. In fact, if you go on the actual CDC website, you'll see that most of them are at least 9 months, if not 12 months, for requiring proof of vaccination. So this should not affect in terms of the country entry. In terms of the evidence related to the breastfeeding, there was, I think in 2010, the first case of an infant who actually acquired vaccine-induced encephalitis, where the mother had been vaccinated, but the child had not been. The child was approximately 4 weeks old when they were exposed through breastfeeding. That was the only mechanism, and they did get encephalitis due to the vaccine virus. Subsequent to that, there was 2 additional case reports that were published that came out of Brazil of, again, infants having an encephalitis. They were all pretty much less than 6 weeks of age when they were exposed. Because the vaccine actually is known to be neurotropic in very young infants, that's why it is contraindicated for children less than 6 months, and all of these infants were exposed. So that has led to some wording related to the precautions and, in this case, the EAP protocol, the contraindication.
Dr. Grog?
Stan Grog, American Osteopathic Association. 3-part comment question. What vaccine do they receive if they get to the border of Uganda and they don't have a yellow fever vaccine, and then they get some type of injection and are allowed into the country? Second part is public education. We get calls, we're in the Bible Belt, if you will, in Tulsa, Oklahoma. And the mission teams that leave just say they're going to Africa and they need a yellow fever vaccine. So public education is necessary, I think, but I don't know how it happens. And maybe this is an add-on to Dr. Hunter's comment about the sites. One of the sites nationwide is the most expensive site for travel consultation and travel vaccines, and so it's questionable. A lot of patients cannot afford that particular site that was chosen throughout the United States. And if there's any comments on that, Dr. Greenberg.
So taking the last question first, understand that we're sensitive to that, but we also had to make decisions months ago about how to set up this program of 250 sites. There was no way for us to know, there is no way for us to know what a site charges for travel counseling or for administration. So those decisions had to be made independent of that sort of information. But we're receptive. We want to gather that information. Certainly we'll make decisions moving forward after we have these 250 sites up and running. That's really the imperative at this point. So I welcome comments from you or from others along those lines.
In regards to your question regarding the vaccines that they would receive if they had received them outside of the United States, short of YFVax and then a vaccine produced in China, the rest of the vaccines that are available in all other locations are actually WHO pre-qualified vaccines, and one of them is actually Stamero. So if your patient may miss it, getting it before they get out the door, they very well could get Stamero when they arrived in Uganda if they needed the vaccination. The other pre-qualified manufacturers include the Brazilian manufacturer called Biomanguinhos, who makes a 17DD vaccine. And then there's also Institut Pasteur Dakar in Senegal that is currently available, can produce vaccine, but is currently offline. And then the final is Chumakov Institute in Russia. And again, those all have been pre-qualified by WHO, and those are what's widely available throughout the rest of the world. I think the last question was public education. We have been doing a lot of outreach to the different partners, trying to keep information updated. We will be publishing another MMWR shortly on the shortages and the implications of that. So we are working on that. We'll be doing some more outreach to specific travel medicine clinics, as well as talking to different people in the state health departments to just make sure that their awareness is there about the need to switch over to the Stammeril protocol, which is allowing us to continue to provide yellow fever vaccine to travelers at risk in the United States.
One last question, Dr. Sutton.
This is just a comment, and it's at the risk of stating the obvious. I wanted to acknowledge Sanofi and CDC, as well as DOD, in working to address this shortage issue. And unfortunately, this is a situation in which a vaccine has only one supplier, and this is what can happen when there's disruption.
Thank you. Okay, thank you very much. We're going to move to a break.